Neonatal sepsis, it is a condition in which bacterial infection in neonates occur, and the neonates bacterial infection occurs in first 4 weeks of life, documented by positive blood culture. In sepsis, blood culture becomes positive. Bacterial infection occurs in first 4 weeks of life. So it is divided into early onset sepsis and late onset sepsis. Means there are two types of sepsis. One is early onset and another is late onset sepsis. In early onset sepsis, infection are caused by early onset sepsis if it occurs in first week within 7 days of life, but if it occurs after 7 days, then that condition is known as late onset sepsis. Causative agents of sepsis are GB streptococcus, E. coli, and Listeria monocytogenes in early onset, while in late onset, GB streptococcus, Staphylococcus aureus, Pseudomonas, E. coli, and Candida are the causative agents. So the presentation of the sepsis are pneumonia and less commonly a septicemia and meningitis present. In late onset, septicemia occurs first, then pneumonia and meningitis can happen. Now, what are the risk factors for development of the sepsis? Risk factors are the low birth weight babies whose weight is less, and the prolonged rupture of membrane, foul smelling liquor, multiple pervaginum examination, maternal fever, and prolonged labor with aspiration of the meconium. And in late onset sepsis, the same causative factors are low birth weight, lack of breastfeed, poor cry, superficial infection, disruption of the skin integrity with needle prick through IV fluid usage. So these are the difference between early onset and late onset factors. So sepsis and the clinical features for sepsis are refusal to feed, a baby will not feed, and baby will become lethargic and unresponsive. Cry will be poor with hypothermia, and breath problems will be there in the baby. So diarrhea and vomiting will occur, fast breath, feet, chest retraction, seizures, uh, and chest retraction with neck retraction, bulging of anterior fontanelle, shock, bleeding, renal failure occurs in the sepsis. So these clinical features will be there. So, what investigation will be performed for sepsis? We will perform CBC, blood culture, C-reactive protein, lumbar puncture, and organ-specific signs symptoms will be investigated by respective labs. So, blood culture is the most important definitive diagnosis for the sepsis. After these labs, we will proceed to the treatment, and the treatment for sepsis will be IV measures, IV fluid, electrolyte balance, nutritional support, and temperature maintenance in the baby. And the specific management will be giving antibiotics because bacteria are causing sepsis, most commonly E. coli. So the antibiotics should be given, and the antibiotics will be ampicillin, gentamicin, and cefotaxime. These antibiotics will be given in the sepsis, and we will treat the neonate and babies from sepsis. So this is sepsis, and in this way we can treat the patient by giving specific measures and general measures. Jaundice neonatorum or neonatal jaundice. It is a condition in which yellow discoloration of skin, mucous membrane, sclera in neonates occur. That condition is known as neonatal jaundice. So, uh, what is the physiology behind development of jaundice? The physiology is bilirubin is a bile pigment which is formed by degradation of heme products of RBC destruction in ineffective erythropoiesis. So let's suppose this is RBC, and when it is destroyed, its heme portion and globin portion are separated, and the heme portion is divided into protoporphyrin and iron. So that protoporphyrin further goes and undergoes some conjugation, and then bilirubin develops. So in this way, the jaundice occur because of excessive accumulation of bilirubin or less excretion of the bilirubin, jaundice develop. So there are different types of jaundice like physiological jaundice and pathological jaundice. Physiological jaundice is described as benign, self-limited, indirect hyperbilirubinemia that resolves by the end of first week of life and requires no treatment. That's why we call it physiological jaundice because it does not require any kind of treatment. Causes of this physiological jaundice are increased bilirubin load on hepatocyte or delayed activity of hepatic enzyme glucuronide transferases. So that's why increased load of hepatocytes, bilirubin on hepatocytes can create physiological jaundice. Clinical features: clinically, jaundice appears in first 24 hours of age and peak bilirubin rise is less than 30 mg per deciliter, and clinical jaundice disappear by 1 week in terms of 2 weeks in preterm infant. But what happens in pathological jaundice? It is described as the jaundice secondary to pathophysiological causes such as indirect hyperbilirubinemia, direct hyperbilirubinemia. Indirect hyperbilirubinemia occurs in sepsis, infections, Abo incompatibility, inborn error metabolism, and Crigler-Najjar syndrome, Gilbert syndrome, hereditary spherocytosis, and pyruvate kinase deficiency. Indirect uh, hyperbilirubinemia occurs. While direct hyperbilirubinemia occurs in obstructive jaundice, choledochal cyst, biliary atresia, and hepatitis A, B, C, direct hyperbilirubinemia develops. So clinical features of pathological jaundice: it appears in first 24 hours. So that is known as pathological jaundice. Now there is the distribution of the jaundice on the basis of time. That jaundice which occurs before 24 hours of the birth, that is pathological jaundice, and the jaundice which occurs after 24 hours up to 1 week or 2 weeks, that is physiological jaundice. So this is distribution of jaundice. Indirect unconjugated hyperbilirubinemia, defined as increased indirect bilirubin either due to increased production of unconjugated bilirubin or decreased uptake of conjugation of unconjugated bilirubin, can give rise to this condition, which is indirect unconjugated hyperbilirubinemia. So the differential diagnosis for this condition are physiological jaundice, increase RBC load from bruising, increase bilirubin from hemolytic diseases like spherocytosis, G6PD, or breastfeed jaundice, breast milk jaundice, sepsis, or inherited disorder of the bilirubin uptake. So these conditions give rise to indirect unconjugated hyperbilirubinemia. And another jaundice is breastfeed jaundice or breast milk jaundice. Now, what is this? Breastfeed jaundice occurs when a baby is not nursing well and not getting many calories, and it occurs commonly in first-time breastfeeding mother. Poor intake leads to weight loss, dehydration, and decreased passage of stool, and decreased excretion of the bilirubin in the stool, and that bilirubin is accumulated, and that condition is known as breastfeed jaundice. Now the treatment is to obtain the lactation consultation and rehydrate the patient or the baby. Jaundice occurs in first day of life is breastfeed jaundice. Another is breast milk jaundice is a jaundice when the glucuronide is present in some breast milks. Infant become jaundiced in 2 weeks of life. Treatment is phototherapy should be given to the baby, and although the bilirubin may rise again, it will not rise to the previous level. So baby is then safely breastfeed and jaundice will gone by 2 to 3 months. In this way, breast milk jaundice can be prevented. Now the another condition is hemolytic jaundice. Hemolytic disease is a newborn. RH incompatibility and ABO incompatibility occurs. Rh incompatibility is a condition in which Rh negative mother give rise to the Rh positive fetus, and then fetal RBC cross the placenta and enter the maternal circulation, and mother's body produce antibodies IgG, and those IgGs can cross placenta of the next upcoming baby who is Rh positive, and that upcoming baby has increased chances for developing hemolytic diseases. So the treatment of this condition will be IM injection of anti-RHD immunoglobulins should be given during pregnancy or soon after birth. In this way, the upcoming baby can be saved. Abo incompatibility is a condition in which less serious causes of pathological jaundice occur, and when the mother is group O and baby is either A or B. So in this way, ABO incompatibility occurs. So these are other inherited disorders of the bilirubin uptake and conjugation like Crigler-Najjar syndrome 1, Crigler-Najjar syndrome 2, and Gilbert syndrome. So we will also look at these diseases in detailed in other videos. So for up to now, we have to only look at that these Crigler-Najjar syndrome type 1 is autosomal recessive, occurs because UDP glucuronide transferase is absent and lead to connectivity. Crigler-Najjar syndrome type 2 is autosomal dominant and UDP glucuronide transferase is decreased. Mild jaundice with no connectivity occurs. Treatment is oral phenobarbital. This Gilbert syndrome is autosomal dominant in which UDP glucuronide transferase is decreased and occurs in adult in response to alcohol, fasting, and strenuous exercise. So in this way, these conditions develop. Now, other type of the jaundice is direct conjugated hyperbilirubinemia. Is defined as when direct bilirubin in the blood exceeds 2 milligram per deciliter, and it is always pathological, means occurs before 24 hours of the birth, and differential diagnosis of direct bilirubinemia will be sepsis, infection, obstructive jaundice, hepatitis A, B, C, fibrosis, cystic fibrosis, and metabolic causes like alpha 1 antitrypsin deficiency. So jaundice should be evaluated, hyperbilirubinemia should be evaluated, CBC, reticulocyte count, serum bilirubin level, and evaluation of sepsis should be done, and management should be given like phototherapy should be given to the baby, light. But during phototherapy, there are certain indications and complications. Indications are infant's gestational maturity should be level checked, bilirubin level should be checked, hemolytic hyperbilirubinemia should be checked, then uh, uh, phototherapy should be given. Complication will be loose stools can be there, erythematous macular rash, overheating, bronze baby syndrome can develop, and uh, these complications can be developed. Phototherapy induced changes in skin can develop during phototherapy. Exchange transfusion should also be given, and pharmacological therapy like antibiotics and IV fluids, RH disease should be maintained, prevented, and phenobarbital should be given in those patients who have conjugated defect. So in this way, we can manage the babies of jaundice, and specific treatment should also be given for obstructive disease like biliary atresia, photojugonostomy, and liver transplant should be done. Cholestasis should be treated by underlying problem, and bowel obstruction should be relieved by surgery and phototherapy. So in this way, we can treat the babies of jaundice. Okay, measles is caused by RNA paramyxovirus. Incubation period of measles virus is 8 to 12 days. Mode of transmission is through respiratory droplets, nose, throat, mouth, and infected person can transmit measles virus. Clinical features of measles is three C's. It is also a mnemonic. One C stands for cough and coryza, and then conjunctivitis develops. So the three C's are clinical features of measles as well. And then coplic spots, which are grayish white spots, develop on buccal mucosa, most commonly opposite to lower first and second molar teeth. these complex spots develop. Pathogenomic of measles are rash, fever, and maculopapular rashes that start behind the ear and then spread down to the body. So these maculopapular rash develops most commonly in measles, and the complications of measles are otitis media. Most common complication is otitis media, bacterial pneumonia, encephalitis, subacute sclerosing panencephalitis are the most common complication of measles. So the management of the measles will be supportive management like hydration and antipyretics should be given. Vitamin A should be given in order to prevent corneal cirrhosis with corneal ulceration, and vaccination against measles should be given. Immune serum globulin is the given for treatment of measles. Mumps. So mumps is caused by RNA paramyxovirus. Incubation period is 14 to 24 days. Infectivity period is contagious and 1 day before and 3 days after swelling. And then mode of transmission is respiratory droplets and secretions. So mumps develops in this way. Clinical features of mumps are fever, headache, malaise, swollen salivary gland, parotid gland swelling, unilateral or bilateral swelling can be there. And then complications of mumps develop like meningoencephalitis, epididymoorchitis, pancreatitis, uveitis, and myocarditis with arthritis can develop in mumps. Diagnosis of the mumps will be clinical, viral, and serological diagnosis can be performed, and management of mumps is supportive care, analgesics, bed rest, semi-solid fluids, and vaccination should be given. Measles, mumps, rubella vaccination. So these are also live vaccines, and these should be given in order to prevent occurrence of mumps. In this way, we can treat mumps and save the life of patients.